Hello, and thank you for coming today. Really appreciate you joining us for lunch, and folks online, thanks so much for chiming in today. We're here to share with you some learnings we have from UVic, Wilfrid Laurier, and locally on older adult homelessness. And my name's Laura Nixon. I am so appreciative of being here with you today. Oh, I guess I have the control of the slides. The fact that we are here on Treaty 7 and Métis Nation Districts 5 and 6 land. I've had the good fortune to live here since graduating from medical school in 1999 and practicing and raising family and just enjoying the beauty of this area. I hail from British Columbia, and we had sent out the objectives before, but like I said, we have some learnings to share with you, including about older people experiencing homelessness and some of their pathways, as well as some innovations that we're aware of. And we're really interested in hearing from yourselves about what you feel are priority areas or topics in this regard. We're working together across 3 provinces to not only mobilize knowledge, but plan for future endeavors together. And so I'll do some brief introductions here and an overview of a very brief overview on a fairly complex topic. Denise will speak about women and gender diverse people's experiences, followed by Laura and their work on encampments, and then I'll be speaking to an intervention co-designed locally around a more social model of care with therapeutic recreation. And so I'd like to start with just a brief overview. This is not my area of expertise, but I have been endeavoring to learn more and more about the history of homelessness and some of the policy contributors. And if we go back to the 1960s and the 1970s, following World War II, the federal government invested very heavily in housing and affordable housing, and committed to ensuring that initially every soldier had a home to return to. In 1973, for example, the federal government committed to building 20,000 units of low-income housing every year, and they succeeded in doing so. Unfortunately, things changed when we moved into the austerity of the 80s, and there was a steady decline in the support federally for housing and offloading of this responsibility to the provinces. They also stopped maintaining now 20, 30-year-old product, and that continued. And so in the early 90s, in 1993, the federal government divested themselves entirely from housing. And in 1995 to 2002, there was actually no new nonprofit housing with federal money. Everything was more or less left to the private market and the responsibility of provinces and the territories. And a lot of the responsibility in the early 2000s ended up being pushed forward from the provinces with inadequate funds to municipalities, who were even less well equipped in terms of the ability to generate income to meet these growing needs. And if we keep in mind that other processes at this time were happening where social assistance rates and social supports were being reduced by provincial governments, again with austerity, the minimum wage was not increasing to meet cost of living, and globalization was impacting permanent stable job availability. And then we had the lack of funding for repairs, as I mentioned. So not only were we not seeing new stock, we weren't maintaining the housing stock that we had. And there started to be more recognition about 2010 by federal and provincial governments that we needed to do something, and small investments were made, but really not in keeping with the need. And the National Housing Strategy has proposed to build 100,000 units over 10 years. But unfortunately, that really pales in comparison to the level of need that we're seeing. layer on in the 2020 to 2023-ish, the pandemic, the squeezing out of people even further, and people trying to avoid breakouts in shelters, and we see the rise of encampments. And so just wanted to offer up that really brief, but hopefully a little bit orienting if it's not an area of deep awareness for yourself. This is the landscape in which we find ourselves, and this helps to understand the numbers of people that we're seeing who are aging while homeless and coming into homelessness later in their lives. And so older people, if you take note that the age groups here are all over the map, the way in which different cities delineate older, it makes it very hard to speak of this in a comprehensive and holistic way. But we have remarkably, we have really quite high numbers here. And according to the last really wide nationwide documentation 2016, older adults were the only age group that were increasing in their shelter use. And so the 10-year plans that have been really quite successful for some demographics, not so much for older people, and we hope to tease this out together today. I wanted to share with you as well, missing from point in time count or a lot of our data is the notion of hidden homelessness. And the Canadian Housing Survey helps us to understand a little bit about this, and other documentation suggests that for each person that we identify who are in these older demographics and experiencing visible homelessness, we probably have almost as many who are experiencing hidden homelessness. So they're couch surfing, they're staying with family, they're staying in untenable short-term rentals, or they're stuck in institutions, typically acute care hospitals or psychiatric hospitals, and not able to be discharged because there's not a suitable community setting for them. So to give you just a bit of a sense of how these forces are coalescing, we've got quite a lot of difficulty accessing and navigating care and unmet care needs for older people. We'll look at shelter settings as an example in just a moment, but this is really quite system-wide, that we are not prepared for an aging population of people experiencing homelessness. They are subject to higher rates of victimization, fragmented care, and barriers to exiting homelessness. And so the cumulative effects of aging in resource deprived or in resource deprived experiences, poor nutrition, exposure to elements, exposure to infectious issues, that's all coalescing to really quite a complex problem for people who are aging in homelessness. And this has been looked at quite extensively and shown that compared to their never homeless counterparts, so always stably housed people, these are the differences in at the same age that people experiencing homelessness find themselves with much higher rates of functional impairments, not able to just manage their day-to-day activities of living, higher rates of vision loss, incontinence, multiple chronic health conditions, and multiple prescribed medications with all of the challenges that arise with that. Much earlier onset of cognitive impairment, falls, and associated with all of this, much higher use of emergency services and increased mortality. And so this is work that's really quite concrete and quantified. And then we have another group. So we have the top group who are aging while experiencing homelessness. So they're experiencing this accelerated aging phenomenon or premature onset of aging. 50 is widely accepted as older when it comes to people experiencing chronic homelessness. And Christine Walsh has referred to it as the no man's land, age 50 to 65, where you don't qualify for the age-based income assistance and many other supports. So then there's also people who are experiencing homelessness for the first time in late life. I won't be able to fully explain this to or discuss this right now, but just wanted to offer up that the socioeconomic and political phenomenon that we're seeing today, the rental housing crisis, food affordability, cost of living, and these factors all contribute to this. And just to touch briefly on poverty and aging, if you look at rates of poverty for single women, age 64 being and under 37% versus 21% once they hit 65, so at least qualifying for some of that age-based income support. But there's disparity that's gender-based and racialized that also is layered in here. And so this is just one dimension that contributes to late life onset of homelessness. So first time after the age of 50, experiencing homelessness, and in some cases, people becoming homeless in their 60s, 70s, and 80s for the first time. And we are not well prepared for this. So just by way of example, in shelters, this is some work out of Toronto in which they looked at shelters' readiness to respond to these different needs. And just to touch a little bit, so if I'm a person who cannot shower or toilet independently, my likelihood of being redirected to a different shelter is better than 50% in this survey. If I can't independently dress, I'm almost the same situation. People with dementia or confusion and behavioral outbursts, you may or may not be able to be accommodated. If you're, and again, the system is set up with the expectation that you have the knowledge and ability to navigate it yourself, that you know your health conditions, and that you're going to seek out help in the right direction, right place at the right time. We talk about right place, right time, right service. And we ground it in the assumption that individuals know how to do that. That this is not the case for a lot of our older people who are experiencing homelessness in our system. So this is a busy slide, but if you can just appreciate the amount of red, that means will be redirected or cannot be accommodated. And then yellow and orange basically mean may or may not be able to be accommodated in shelters. And so they're just not environments that are resourced or structured with older people's needs in mind. And so we have this situation of disproportionate growth of older people experiencing homelessness. It's beyond population aging, it's structural, it's systemic, it's driven by policy and systems and programs that are just not equipped to accommodate the needs. And then we have the unique vulnerabilities with aging. Dementia, social isolation, complex physical and mental health challenges, contributing to behaviors that are not supported in rental environments and contribute to people being evicted or people being evicted from supportive living environments. And I'll talk a bit more about that in my turn. And then just by way of example, one setting that is part of our massive homeless serving sector, shelters are not designed or equipped to respond to these growing needs. And so we have this situation where we hope today that we together identify some of the paths forward, and really would like to hear from you about what you think are priority areas for us to pursue as a team. We're a 3-province team, and we're growing, and welcome your input. And I'll just hand that over to Dr. Cloutier.
Thank you very much, Laura. Let me just get set up here. Okay. Yes, okay. Now, you can see the slides then, can you? Okay, I can go. Okay.
Yes, please.
Yes, thank you so much, Lara. Thank you for that introduction. And I'm going to end up touching on many of the points that you raised in your overall comments. And I just want to mention today that I'm coming from the Lekwungen People's Territory, the Songhees, Esquimalt, and Wasanik First Nations. And I'm going to share with you some highlights from our research project called Solutions to Housing and Health for Older Women, or the SHOW project. It's a qualitative research project where we looked at women's experiences in the homeless serving sector and violence against women serving sectors. So here's our research team. It included academic researchers from nursing, sociology, geography, and it included 4 co-researchers, women with lived expertise of homelessness, as well as the Alliance to End Homelessness in the Capital Region and the Community Social Planning Council. And my purpose this morning is to share with you some insights from the SHOW project to illuminate older women's pathways into and out of homelessness, to share with you some of their life experiences, and to highlight some of their needs and wishes and identify some priority recommendations that came out of our research together. So we interviewed 20 women with lived expertise between the ages of 48 to 78 years of age from July to November 2021 in the earlier parts of the pandemic. And we also interviewed 22 service providers, but not really going to share too many insights from that group. I'm going to focus more on the older women's experiences. So as Laura mentioned, we get a lot of our information from point in time data. So on women 50 plus in Victoria, BC, in 2018, there were 62 women age 50 and over in the study, and 75 women in 2020. And that's an increase of 21%. So again, we see this increase in homelessness among older adult populations. 30 out of 71 became homeless for the first time at age 40 or older, and 6 were homeless for the first time at age 60. Again, identifying this growing phenomena. And also wanting to highlight that the number one reason they would not stay in a shelter, so for older women particularly important, they don't feel safe in these types of environments. In terms of some background information and what we know about older women's experiences, essentially they accumulate disadvantages across the life course. And we used an intersectional life course approach where we could focus on intersections among age, gender, income, occupation, life experience, etc. And so we know that older women have expertise with homelessness that is the result of exposure to multiple disadvantages over their lives. And we know that the loss of housing in later life occurs at a time when they have fewer resources to help them regain stability due to their physical, social, and mental challenges. As Laura mentioned, there is a lot of hidden homelessness among older persons and women in particular. They tend to rely on informal and relational supports. So the couch surfing, sleeping in cars, and sometimes going back to partners who have been abusive because they have no other alternatives. We know that older women are often overlooked in housing research because of this hidden or invisible nature of their homelessness and housing insecurity. And we know that housing supports rarely account for their specific and diverse needs for safety, accessibility, and privacy. Some of the findings from our interviews with the 20 women: 85% of participants have felt social alienation during their experiences of homelessness. Half experienced feelings of internalized shame, and 8 out of 20 avoided asking for or receiving help that they needed. 16 out of 20 or 80% have felt unseen or unheard with regards to services and policies. The participants were equally likely to report experiences of harm, neglect, abuses of power, discrimination that they had experienced. 85% of participants on the lower left there reported experiencing discrimination in housing services, 9 out of 20 in medical services, housing market 2 out of 20, and society at large 6 out of 20. The women mentioned the importance of personal advocates as crucial sources of support for them. And those advocates included shelter staff members, medical personnel, etc. A sense of community was reported as very important for many of the individuals as a key component of their well-being. So 15 out of 20 identified the importance of a sense of community. I'm going to highlight now some of the simple wishes that women wanted again from their qualitative interviews. One said, a home means a key to the front door where I can walk through my own front door. I don't even have that here. I have to be buzzed in. Another said, I would like a bathtub and a closet for my clothes. A bathtub, a closet, a kitchen sink, a key to my own front door, and I would call that my home. A third said, so I would like space. The question of light, I'd like light. I mean, these are all aesthetics. I would just really like to have some autonomy in my home, not be connected to a building that is identified. There are plaques and signs inside the building, and there's a stigma around people that live in this building. So you get comments and looks when you go in and out of the building. And there's always drug dealers around, and that's really awful for me. I mean, I'm a little bit used to it, but I still find it really difficult that I have to bypass them or if I'm accosted by them. Women and service providers identified the following things as important to their sense of health and well-being. Safety being the highest priority, as most have a history of experiences of trauma and violence, often with male partners and others, such as other residents, staff, and police. Adequate reporting and accountability mechanisms are needed in this regard. Space. The women consistently identified the importance of having their own room or apartment that they could decorate and make their own. As you saw before, with the emphasis on having a door, a lock, a hot plate, and preferably or ideally a bathtub. Socially, women identify the importance of having a communal space to engage with others, to build relationships and friendships, and to create a sense of community and belonging. They need particular kinds of supports that are tailored to the individuals that they are and that are ongoing rather than episodic and that are sustainable. There's a need for housing and services and not housing or services, as is sometimes positioned in policy that once people have a home, they will be intact and stable and ready to go. That's simply not the case. They also need to have access to counseling, substance use services, healthcare, long-term care, etc. So we built this infographic to kind of gather information on their experiences. I don't know if you can see it very well, but at the top, it talks about the pathways into homelessness, the conditions and circumstances, which are personal crises, evictions, loss of jobs, leaving abusive partners, etc. And then they lose their housing. And then they can enter this kind of cyclone, tornado of hopelessness and isolation, and where they experience hidden homelessness, where they have negative encounters with law enforcement, experience deteriorating physical and mental health, violence, etc. If they're lucky, they move through particular kinds of transition housing, emergency housing, emergency shelters that give them access to second stage housing in this case. Sometimes they cycle through shelters. Sometimes they will gain the benefit of being in particular environments that lead to supportive housing, subsidized housing, and market housing. But for some, they will cycle back into this system because they don't get consistent housing and service support. And if they are to be looked after and become well, they need to be able to develop routes that focus on the personal advocates that can help them exit homelessness safely. They have to have access to trauma-informed care. improved access to physical and mental health supports, culturally safe care, and this can give them relative stability for a period of time that ideally will lead to healing from trauma, that will lead to them being advocates for others, having independence from abusers, reconnecting with family and friends, overcoming shame, etc. We were quite happy, and we continue to use the intersectional life course perspective, which alerts us to a sense of the stacked or layered vulnerability of older women in this sector. On the right-hand side, you see the depiction of an iceberg and also a Jenga game, kind of like the analogy of the iceberg, because the homelessness that we can see, as Lara mentioned too, is only a small part of the homelessness that exists. And the Jenga game, we use this analogy early on for our understanding, because if you pull out any particular piece of the puzzle at various times for women, their situation becomes more unstable, and they're likely to cycle in and out of homelessness or experience a rapid crisis that brings them into the system. It's important to emphasize that their experiences are not linear. For the most part, women will cycle in and out of the system, return to shelters and supportive housing. They face a tremendous number of barriers on the basis of inadequate system capacity, as Lara mentioned, due to the dismantling of the sector from the 1970s. They have a very difficult time navigating the system. They are subject to a lot of bureaucracy, paperwork, eligibility criteria. They find themselves in unsuitable housing environments, and they regularly experience assaults, physical assaults, and mental and social assaults on their personhood and dignity. For women to exit homelessness successfully, a number of variables seem to need to come together. They need to be connected to a personal advocate who helps them over time, or a social network. They need to develop friends. They need to find secure and stable housing and have access to appropriate services when needed. So we came up with these what we think of as essential priority recommendations for women. 4 of them. First, to recognize their personhood. We need to find opportunities to support humanity and dignity and not patronize and undermine women. They need help navigating and accessing services effectively and in time-sensitive ways. They already feel invisible, traumatized, and easily ignored or displaced. We need a system that's oriented towards person-centered, whole-person care rather than system-centered care, which requires meeting people where they are at and adapting existing and building new services that can be targeted more towards the needs of diverse and complex women. Age, gender, and culturally sensitive lenses must always underlie the care and support provided. Need access to trauma and violence-informed care, specialized teams and individuals with this kind of training to address safety and the links between trauma, violence, behavioral and health outcomes, and structural disadvantages. And finally, we need to expand rather than contract eligibility criteria. One possibility is letting people stay where they are for longer. There's a lot of movement, shuffling people from place to place in the system, and that's very destabilizing and unnecessary. In the long run, it's cheaper and more effective to house people properly to begin with, rather than hand them over from one system to the next in a process of fragmentation and continual displacement and replacement. So thank you. I want to acknowledge and thank all of the women and service providers who shared their time and expertise with us. And I'm thinking, are we taking questions now or afterwards, Laura?
Thanks, Denise. I will have Laura present, and then we'll open it up to discussion. So please, yes, if you have questions, please just make a note. And for people in the Zoom, please also just put your questions in the chat, and we'll do our darndest to get to them. I don't know. This is working now. Can you guys advance the slides? Maybe. Hey, there we go.
Thanks so much for your help. Okay, thanks so much for the invitation to be here today, Laura. My presentation is about a research project with a managed encampment in Waterloo, Ontario. I'm an assistant professor in the political science department at Wilfrid Laurier University. Wilfrid Laurier and a Better Tent City are located on the territory of the Neutral, Anishinaabe, and Haudenosaunee peoples on the Haldimand Tract. 6 nations of the Grand River currently reside on less than 5% of the original Haldimand Tract territory. And Indigenous peoples with roots across Turtle Island call a Better Tent City a for now home. So like many communities of folks experiencing unsheltered homelessness, we do have Indigenous peoples overrepresented in that community. I also want to note that I'm really grateful for the support, guidance, and investment of the A Better Tent City community in this work, as well as to a number of Laurier graduate students who have assisted with this project over the last 18 months. So I want to start off by talking about what a managed encampment is. Encampments are emergency accommodations established by people who are unhoused on public or private lands, often without permission. Both push and pull factors can lead people to seek shelters in encampments. Push factors can be a lack of affordable and appropriate housing options, too few shelter spaces in a community, or emergency shelter spaces that are not accessible for a variety of reasons. Pull factors, factors that draw people towards encampments, can be that there may be a sense of community associated with that living arrangement, as well as a degree of stability. So when your choice is to sleep in an encampment or an emergency shelter, you may have to line up every night for a spot. You may not be guaranteed that you'll get a spot the next night. You may not be able to take your belongings with you. So that sense of stability, as well as a degree of autonomy. Drawing on an American researcher, Herring, the relationship between encampments and the state can be described as contested, tolerated, accommodated, or co-opted. Contested is when the state, so typically the local government, criminalizes the encampments, evicts it very quickly. Tolerated means an encampment is not permitted. However, action may not be taken immediately to evict the encampment. Accommodated is an encampment that is permitted by the state, usually run by a not-for-profit organization, and co-opted is an encampment formally run by the city or government. Accommodated and co-opted encampments are 2 forms of managed encampments with some degree of recognition as legitimate forms of emergency shelter. So what is a Better Tent City? Better Tent City is a community-based initiative that provides homes to individuals experiencing homelessness in Kitchener, Ontario, which is a city of about 250,000 people located 80 kilometers southwest of Toronto. A Better Tent City was established in 2020. And I don't have time today to talk about the process of how it came to be, but that's an interesting story in and of itself. The land it's currently located on is owned by the City of Kitchener as well as the Waterloo District School Board. And they have permission to stay on that land until 2025. On site, there are 42 heated cabins with access to shared amenities, including washrooms, laundry, a lounge space, and a kitchen. About 50 people have signed housing agreements living there, but more like 100 people are on site at any given time. And a better tent city provides food for residents, connection to some services on site, paid resident jobs, opportunities to participate in decision-making and site governance. Anecdotally and from direct experience, we know that people at a better tent city were experiencing homelessness prior to coming to a better tent city, and that many have disabilities, complex health needs, use substances that are criminalized, and some struggle with substance misuse and addiction. However, at the time that we started working with a better tent city, there was very little systematic knowledge about the work that was being done. So just to give you a bit of an overview of the research project, in 2022 and 2023, we started working with a better tent city, building relationships, volunteering on site, learning more about what they were doing. One of the things that emerged from this initial relationship building phase was a need for some more systematic data around what was happening there. So May 2023, we co-designed a survey and received research ethics board approval from Wilfrid Laurier University. And in August, we were able to do surveys with people on site at a better tent city. This past January, the Better Tent City Board reviewed the findings, and we are hoping to have a report and community report back in the next month or two. In terms of what we did, the surveys focused on some demographic information, some information about health and well-being, information about access to food and services, and sense of safety and belonging on site. Surveys were administered orally by trained research assistants, and it was quite a process figuring out how to do this survey in a good way, or what we felt was a reasonably good way. 17 questions taking about 15 to 30 minutes to complete. 68 individuals initiated the survey and about 52 completed it. So a number of individuals started the survey and then for different reasons didn't complete the survey. So I want to jump in and talk a little bit about what we learned about a better tent city and some of our findings. So among respondents currently staying at a better tent city, we found that 88% were experiencing homelessness immediately prior to coming there, with 51% experiencing unsheltered homelessness, 16% emergency sheltered, 14% provisionally accommodated. A further 7% became homeless after leaving an institution like a hospital or jail. And it's interesting that the majority of folks were not in the emergency shelter system, often because of factors like those that Lara mentioned during her presentation. Shelters were not a good fit. 75% of respondents identified as having a disability. So a population where there were a number of folks who identified as having a disability. It fits with sort of the general knowledge we have of the site of many people dealing with complex health needs. On average, the people staying at a better tent city are older than those experiencing homelessness in Waterloo region, according to point in time count data. And on this chart, I just have a bar graph showing the ages that people reported. 20% of respondents reported being able to connect with a primary healthcare provider while staying at a better tent city. And over 50% reported connecting with other healthcare services, specifically something called the Sanguine Mobile Healthcare Clinic, harm reduction services. Other participants reported connecting with social assistance, ID clinics, dental care, a few, arts-based programming, and Indigenous specific services. So the dominant way that folks were able to connect with those healthcare services was through service provision on site. With the exception that because there's no primary healthcare provision on site, those 20% were connected through initial connection with a healthcare service on site that then referred them through to primary care. Oh, I need to work on my color selection for pie charts. That's what I'm learning. So the yellow is not really standing out here. So we wanted to get a sense of how people understood the impact of staying at a better tent city. And so we asked a series of questions focused on trying to get a more holistic understanding of well-being. So we asked, how has staying at a better tent city affected your physical and mental health? How has it affected your living conditions? And how has it affected your support network? And what we found was for the vast majority of respondents, which is the blue-purple indicated on the pie chart, there was improvement. So about 75% across the board, with a small number saying that their physical and mental health and living conditions had worsened since coming there, and a proportion, about 20% across the board, saying no change. Something interesting for the purposes of this conversation is that in terms of when we break down responses to the question, how has staying at a better tent city affected your physical and mental well-being support network and living conditions by age, we find that respondents who were 50 and older were more likely to report improvement. And so this is just a sort of preliminary finding. You'll see that the 95% confidence intervals on these bars are overlapping, so there's some distinction, but it maybe points to an area for further research and investigation. So I want to talk a little bit about what I would call the elephant in the room. So we have a sense that a better tent city is providing a service to folks who may not be able to access the emergency shelter system, who don't have affordable, accessible housing options either. But at the same time, a better tent city is a managed encampment. People are living in sheds with electricity, but they don't have their own washrooms. One of the things that people noted was the importance of having, it's funny, as Denise was presenting, I was thinking about the door that locks. That really came up. People really liked having a door that locks, so they have a door like that locks. But are these tiny sheds really adequate housing? Is this what we should be looking to move people into? Another concern that's been raised locally when it comes to thinking about how the municipality allocates their funding, is this consistent with the Housing First model, which seeks to move people into permanent housing? So I called a better tent city a for now home, which is, I think, how many folks understand it. And so this idea that even if this is a transitional housing that people can be accommodated in, while there's a search for permanent housing, should we be moving our resources into more permanent housing options? And then, of course, the question of, well, what if folks never leave, right? What if this temporary situation becomes a permanent one? And we do know that most of the residents staying at a better tent city have been there for over a year. And so probably what I would say to this, these concerns is I do not think that tiny sheds are adequate housing. And I think we've got a fairly robust definition of adequate housing in both Canadian and international housing work. However, for a lot of folks, there's no other options right now. And so I do think it serves a meaningful purpose and gap. And one of the things that a number of survey respondents told us was that quite simply, they had nowhere else to go. And they did not think they would have survived the past winter. They wouldn't be accessing essential services and care that they needed if they weren't there. So again, I think the fact that something like a better tent city is a policy solution we're seriously grappling with speaks to just how badly we're having systems failures around housing right now. However, I think that it's a great example of a community initiative that is having a meaningful difference in people's day-to-day lives. These are just some sources. I know Lara has handouts as well.
You may have picked up one that, and I'm sorry, Denise's beautiful one page of the pathways into homelessness for women. I've emailed it to Demalati in case you would put it in the Zoom chat, the PDF, that we will definitely distribute that and some other things after our session. Thank you so much, Laura. That's really, really interesting work. And I think builds nicely on Denise's, and we're going to move a little bit into a different model of support and care. And this is work I've had the privilege of being involved with many years, but more specifically in terms of better understanding what's happening there in the last 7. And I am presenting on behalf of many people, including a robust group of advisors from our community, and two of whom are with us today in community liaison roles. We'll introduce Dawn and Teresa in a few minutes, and then our team, which hails from a number of different institutions, and one of our key community partners, Caitlin Lucas. We have the good fortune to have some funding support in the last currently in the last 4 or 5 years, and I am a family physician with a couple of local organizations. I want to start out with a little bit on substance use and aging as far as a bit of context here, because the setting that I'm going to be speaking about is a facility that has offered harm reduction supports for many years, since it opened in 2005, and it has been a bit of a one of a kind in the city in which it's situated. And I just wanted to share a bit about, because pain experiences tend to increase with age and use of our bodies and various other things. Older people are typically take more opioids and more frequently than people who are younger. And our current generation of people aging in their later years have different relationships with substances than previous generations. They have more permissive attitudes towards drug use, easier access, and greater exposure to illicit substances than any previous generation. This is Canadian work. And older adults have now have a higher prevalence of substance use and substance use challenges than previous generations. And if you layer in precarious housing or homelessness, there's a real chicken and egg phenomenon there. People who have challenges with substances are more likely to become unstable in their housing, and unstable housing contributes for a lot of people, not everybody, but for some, to increased use of substances and problems related. And abstinence from substance use is not possible nor desired by many older people. And there have been calls for incorporation of harm reduction approaches in aged care for many years. And there's been attention. This is Benjamin Hand's work. He drew the parallels between good geriatric care being very much in line with the principles and values of harm reduction. And just so everybody is on, so we're all kind of in sync here, a reminder that harm reduction is focusing on policies, programs, and practices that aim to mitigate the consequences or the negative impacts, both on health, and social and legal experiences for people, and as it relates not only to the use of substances themselves, but also related to our drug policies and drug laws. So the criminalization of people who use drugs has been highly problematic. And this is, of course, grounded in a social justice perspective, and it's striving to offer supports without the precondition of people stopping using their substances. The other piece I wanted to just offer up as a heuristic to consider, and many people obviously from public health in this audience, I assume, will be very aware of ecological approaches, but I really like this as a heuristic because it draws attention to not only the risk of harm that ensues from individuals' behaviors and apparent choices, it helps us to look at the environment itself in multiple intersecting and sometimes compounding dimensions, and see the opportunities for the possibility of reducing harm through intervening at the level of the environment instead of just relying on the individual to make change. So I find it very empowering as a practitioner and as a researcher. And so with that in mind, this environment that we will refer to as Harbor House offers 68 beds for all genders. And there's 24/7 on-site staff. There's full meal service and housekeeping supports, in-house laundry. And like I said, they've been offering harm reduction supports on a voluntary basis since 2005. Far before it was vogue to use the term managed alcohol program, they were offering managed alcohol supports. And that could look like whatever that individual might want and need. It was highly individualized from the get-go and offered out of recognition by the social work team of people's needs. They were one of the few facilities that permitted indoor smoking in the city. And the visiting health supports include a strong relationship with home care nursing. A dedicated RN would be on site most days of Monday to Friday with a team of mostly stable team of healthcare aides also offering up some continuity, and then visiting primary care in the past had been nurse practitioner and family physician combination. Psychiatry in a sort of community treatment team model was available to some people, and geriatric medicine did visiting consults for a wonderful stretch before COVID hit. In collaboration with the housing operator, we were able to take their administrative records, which was really interesting, on paper in various stages from going back to 2005. And we were able to match that to administrative health data for 158 people out of the about 184, I believe it was, who had ever lived there, and compare 3 years before to 3 years after moving into Harbor House and look at their health service costs. Was our primary focus. And as you can see with the dotted line in the middle, there was an immediate cost savings, which is not shocking. If you're moving people out of an acute care bed, you're immediately saving money by doing that. But what we really were struck by was the continued decline in health or improvement in healthcare costs over time, over the period of 3 years after. So this was with their base model. I had the good fortune to work with Victoria Burns, who's now faculty here at the U of C in social work. And we did a qualitative study with the people living and working in this setting to try to better understand what it was like to live in a harm and work in a harm reduction environment. And I'll just draw your attention, sorry, this is a bit busy, but at the core, harm reduction approaches and policy enabled the development of trusting relationships, which in turn enabled the reduction of harm in this setting. People continue to use substances, and from the residents' perspective, they really endorsed a sense of belonging and feeling respected, and trusting staff, and from that, accepting their help. And the staff expressed how being able to use this harm reduction approach really helped them to get to know people and earn proximity such that they could offer up unique negotiated supports and create this modified microenvironment that was supported by the congregate setting itself, the communal dining area, lots of opportunity for micro interactions to get to know one another and just have those daily expressions of regard as individuals, not doctor-patient and limited to a medical model. So much more of a social model of care. So from our learnings with this work, we came to understand, because their funding is actually the same as a shelter, that's the level of funding that they received, the operators here. They weren't able to offer more than really time-limited, summer student-based leisure and recreation. It's literally funded by the pop bottle fund, the empty pop bottle fund that they had with a bin in the dining room. And so there was nothing through the winter, and we discussed with the operator and people in the setting, well, what if we applied for some funds to build a program together? And so that's what we did. And this is our advisory group. And we secured 3 years of funding through Health Canada under their substance use and addiction program. We made the pitch. This is harm reduction. If we can offer people alternative activities and quality of life oriented supports. So the intervention had other dimensions. I'm going to just focus our talk right now on the therapeutic recreation intervention. So with the community, we build a program. And on the right-hand side, you can see the different domains. I'm sorry that my colors aren't the best here either, Laura. Here's a sampling of the activities that we were able to offer. And if you follow on the left, the gray line, so starting in January of 2020, The program built quite quickly in terms of people interested in participating, but then we had quite a thumping of the outbreak of COVID. Things dropped to zero because we couldn't do anything by groups, but we slowly built it up again. By the second year, which is the blue line, you can see with a couple of exceptions when we had 2 outbreaks, which we were pretty excited to only undergo 2 outbreaks in this setting. And you can see really robust levels of participation. People described a new sense of confidence to try things they hadn't tried or thought they would ever try in the past. People also engaged, and I'll draw your attention to the blue box here. Residents identified 253 goals that they had related to this programming. And just to share, it will never leave my mind, one of our participants in the qualitative study talked about goal setting as being very much avoided and widely recognized by staff and endorsed by the community that it was just another way to fail. So don't ask me to set goals. And our experience here was entirely different. It was really remarkable. And the nature of goals changed over time. It started with physical. People kind of identified recreation. Oh, I guess I better get moving. And over time, they actually endorsed cognitive and social and spiritual goals. So we thought that was really interesting trend. And on the right, this was also, I'm going to use my colleague's term, very chuffing to see people reporting an improvement in their quality of life during a pandemic, which I have to be honest, is not at all in keeping with a harm reduction approach. Chasing people with thermometer, asking, where are you going? When are you coming back? Where are you going to be, right? Are you coughing? Are you sneezing, right? And literally having to enforce these public health. And as you saw, we only had 2 small outbreaks and no deaths. So people were tolerant of that. And this intervention, I have to say, it was really quite remarkable to be able to add that to our medical model of care with our psychiatry and other providers. And then the other thing that people really endorsed, and this is one of my favorite quotes by a gentleman in this picture, that they were able to enlist one another and connect with one another through things like euchre and card games. And identifying this as a huge thing for him to join in the card game. And in 4 years had never come to any sort of activity other than to take a meal in the dining room. And so we had such enthusiasm from the community there. They wanted to make a film. This was their wish, and we did. And it's a short film, 20 minutes. If you're interested, it's on the resource sheet. And we also have quite a nice implementation handbook that the remarkable therapeutic or rec therapist who stuck with us the whole 3 years. She was really quite a force, and we're continuing to work with her. So this is these are resources available if anyone has an interest. And we are continuing to work together with this community and an expanded community to explore successful aging from the perspective of older people with experiences of homelessness. We have a poster in the back here of our mask making workshop with them. And this talk today is part of some CIHR funded work that we're doing with Laura in Ontario and some others from Toronto and some folks in BC, including Denise, to share our knowledges and but as much as anything, invite people's perspectives on this topic and this community of our people that we have the good fortune to work with and serve, and would like to open up to questions, comments, feedback, suggestions, please.
There are 2 questions online. One person asks if they will be able to get access to the slides after this presentation.
I'm happy to send something out.
Okay. And then the next person says, I followed a relative on Facebook who was homeless for several years. a couple of things that were important to her were access to social media and keeping and feeding her dog with her. Did you find this as well in your research?
Access to, if I can just sort of broaden it, so social media and the internet and email and the like is something that I would say is a really big priority for some of the people that we've been able to hear from, and a very important means by which to connect. One individual who identified as gender fluid, it was very, very important for them to connect with people outside the immediate environment in which they were living. And this was a person in their late 60s. Pets, yes, we've certainly heard from a wide array of people the importance of animal companions and interest in a house cat or dog, like literally shared responsibility, and or the option. We had one person working very closely with us who had birds, and they were incredibly important to them as companions, and yeah, just a much more whole part of their living.
There's another question. Ralph, you could go ahead and unmute.
Okay, sure. I'm just curious about the tiny homes, and how long did it take to develop that small village? Like, was it 6 months, a year? How quickly was it able to be erected? And
Yeah.
and then I guess the other question would be were there any evictions? Were there any people that had to be removed because of their behaviors, or was it basically tolerated and dealt with on so they didn't have to leave? And then how big do you think those villages should be if you were to create them? Is 50 too big? Is 20 too big? What size do you think would be appropriate to do if you were going to do something like that? So thank you.
Yeah, thank you so much for those questions, Ralph. Those are really great questions. In terms of how quickly, so there's a bit of a difference, I would say, between managed encampment sites run by municipalities versus ones that start through grassroots community organizing. And so a Better Tent City was a case of doing first and asking for forgiveness later. So initially it was established at what was formerly a bar with the owner's permission. It was no longer being used for that purpose. The owner wanted to, knew somebody who was letting people who were unhoused sleep in their convenience stores, that I've got more space here, come stay here. And it was a process of, it started in 2020 pretty immediately and some of the folks that are still there joined in 2020, and has moved locations a couple times in terms of finding sufficient space. So it started really quickly as partly, I think, a pandemic response, but again, without permission, and then essentially right now, when there's pushback, the answer often is that there's simply nowhere else for these 50 plus people to go. There's not other spaces in the emergency system. And so if you're going to terminate this, what are you going to do? In terms of eviction, so one of the reasons why I think a Better Tent City fills a gap is because it provides a more flexible arrangement for folks that are dealing with complicated behavioral challenge, other sorts of challenges. So occasionally folks do have to be asked to leave. And the process of that is usually trying to work with someone to resolve an issue. But there is a code of conduct. And if people, for example, if people are repeatedly stealing from other people, they may eventually be asked to leave. It's a pretty infrequent occurrence, I would say. Again, partly because there is a bit more flexibility and discretion. And I think partly because of that door that locks piece, where people, do have that space to go to that's private, that they can cool off. In terms of the size, it's interesting. There's a number of different models for this. And I would say most do not have 50 people living on site. I know Homes for Heroes, which is an initiative that has a site in Calgary, as well as one in Kingston, Ontario. They set it at 25, and they say 25 is the best number that we can manage, keeps the community manageable. There's the Archdiocese of Halifax and the City of Halifax have a partnership where they do scattered site housing. So it's a bit different. And they do 2 to 3 in each location. So they've been locating tiny homes for people experiencing homelessness on churches throughout the, or church property throughout the city. So there are a number of different models. The challenge with 50 is just that the interpersonal dynamics become much more complicated as soon as you're, but the benefit to having collectivity, right, is that importance of building that social network, which is something that people really talked about as a positive impact of staying there.
Yeah, if I could just add one comment. I recently attended a conference or a webinar that Harvard University had on manufactured housing and looked at how quickly and how cheaply you could create capacity that way. And I'm just thinking that might be something to look at, where again, maybe you include a kitchen and a bathroom in the village, but basically for everyone. And they were quoting prices that were about 30% of what stick-built housing is, and again, the how long it takes to do stick-built housing. So just something to think about.
Sure. And I didn't mention, but I think that the tiny homes at a better tent city were, I want to say, in the range of about 20,000 each, something like that. No, I'm off. Don't quote me. I shouldn't have said it. I need to double check. I take it all back. I'm worried I'm getting my tiny home initiatives mixed up. I don't think they were that much.
We have time for one more question here that asks, what do we do to homeless people who do not want to be in the home, but on the streets, but access other health services in the community?
If the question is about health services, I can speak a little bit to Calgary's situation. There are definitely some outreach teams that visit people who are encamped as in individual settings or clusters or otherwise. And then there are also I would say very low barrier supports largely through our community health centers and urgent care centers and the emergency departments. We do have the ARCH team at the Peter Lougheed, which was an initiative that started in Edmonton at the Royal Alex Hospital and was brought to the Peter Lougheed Hospital, who definitely are available to support people presenting to emergency and are experiencing homelessness, low income, and substance use challenges are kind of the cluster of things that the ARCH team was developed with community guidance in Edmonton and here. And Dawn and I were part of that evaluation and scaling up. So hopefully that answers the person's question a little bit. I would like to just, in our remaining few minutes, have 5 minutes before we need to vacate the premises for the next event. If anybody has any additional comments or questions, please.
So part of the demographics, my question is, was there anything tracked on vehicle dwellers? Second question is, majority of the people in the research that you look at, are they Canadian born or new to Canada?
And I'm sorry, I missed her name.
For
Are you asking the commissioner said
any of you, any three of you speak?
Yeah.
Today.
So a chunk of people we surveyed were not staying there, not staying in vehicles either, mostly camping elsewhere. I think everybody was born in Canada, almost everybody. Yeah.
Denise, would you like to comment on your perspective?
Sure. That would be true for our study as well, that the women were born in Canada. And there were 5 that were couch surfing and 3 sleeping in cars and 4 cycling back and forth between abusers. And I think that's important in terms of COVID. It kind of opened up some opportunities for more creative thinking with the sheltering hotels that came on stream. But some people felt safer in their cars in our study than they did in the sheltering hotels again. So I think that's another interesting finding. Thanks for the question.
I have a comment or question, I guess. I 100% agree with, I love the idea of the shelters, the little homes. And also capping it, because the more you get, the more issues you have. The idea of a locked door, 100% on that one. One of the things is not just with the hiddenness and homelessness, the safety issues. The multiple getting jumped, robbed, beaten, raped, all that type of stuff goes hand in hand with being homeless. Trauma supports, I think, are really, really, really important because it is the reason why people pick up drugs in the first place. Even implementing programs like the 12 steps of trauma would be a really good idea with those peer supports as well. I see there's somebody else, so I'll just stop there.
Thank you so much, Teresa. I was just gonna, Jana, as yourself, sure.
So, you probably know John Brown, the dean of, Saville, yes, school, yeah, he's the school park. Had designed these, laneway homes, which were designed to, you could basically put them in the backyard of someone's home, and they were designed to actually help care for older adults that had health issues, and so they could be equipped with needed oxygen and medical. They were just kind of self-contained suites that, you know, so you could keep a relative that needed sort of assistance close, but in their own space. And he's now exploring with Brenda Stratford to look at using them, kind of creating modular kind of continuing care facilities where you'd actually, you know, put a bunch of them together with common spaces. And so they're actually they're going to be, I think they're trying to get funding to pilot it. I think they're going to move forward regardless in their, where they used to have a facility in Forest Lawn in Calgary. So they're going to, so I mean, it was just an interesting model in terms of, you have your own space, they can expand or contract depending on need. But I think they're much more expensive though to build. They're $20,000. I think they're more than 200,000, like, right? But
I've been to some presentations and the technology involved is really remarkable.
yeah, but I think that's kind of an interesting idea, right? Because you
Yes.
can easily construct them and move them and
Co-locate.
Yeah.
the-
although my understanding with these is the art quite to the point where they could become more affordable, right? The fabrication is still quite expensive to do it, but
Thank you.
yeah, I think it's might be an opportunity for collaboration with this group. And I don't know that he's ever, but definitely the Brenda Stratford's Forest Lawn spot would be the population.
That would be very interesting.
Yeah.
So, thank you.
Okay, my name is Define and I'm a registered psychiatric nurse. I work in this hospital as well. And this topic is quite important to me, and that's why when the educator sent out the notice, I requested to be part of it because homelessness also impacts in what we do. Most times, a lot of I work in the inpatient, acute adult psychiatry. Most times they are ready for discharge, but they have no place to be discharged. And our model is that we don't discharge them to homelessness. So here we sometimes put a referral to Robert's House or Hamilton House, but there are much to what they can do. Sometimes they don't have the facility or they have to be in a long waiting list for there to be an opening for them. So my main question is, how do you guys get funding? And how could you expand what you are doing, which is really fantastic, making sure that we have a lot of all these kind of homes or houses out there that can support people in this population.
Would you like to speak to that? Denise, would you like to speak from the Victoria perspective in terms of funding availability for innovative models of care?
Well, that's such an important question, and thank you for it. I guess as you were speaking, I was thinking in my mind to ask Laura and Lara where the money came from for these models they're talking about. But the work that Ruth and I and others have been doing in Victoria has been more or less saying we're not going to get the housing we need in quick enough time. So without the housing, so there, that housing first, but not housing only idea, what can we do that's more mobilizing services, changing the way the system functions, getting better trauma-informed training as we wait for the supports to come on stream. So yeah, we have a new premier who's invested very much in housing and homelessness, and hopefully we'll see more interest this way, but it's such an important area, and we're a little bit stalled on that front here.
Yeah, I mean, in terms of a better tent city, so initially it was the land was a willing landlord, Ron Doyle, who had this space, and then Ron passed away and the property was sold, and so there was a need for the tiny homes, which were donated by a private donor. And so basically a better tent city is now a formal recognized not-for-profit and charity. And a lot of grant applications and grant writing, right, is how they support the operating costs. The other piece is folks who are on social assistance in Ontario get a housing allowance. And so for folks that are connected with social assistance, that housing allowance does go to a better tent city, but it's not sufficient to meet the operating costs. But that is a piece of the revenue. And then a little bit of money initially from the city of Kitchener and recently from the region of Waterloo, but you know, really government funding has been a minor part of the story to date. And so it's challenging in terms of being able to provide, like Laura, like we have to talk about therapeutic recreation because that's something that they're really trying to pick up there and offer more of. But you know, the funding environment is so constrained. So it has been challenging to make the case because nobody likes any sort of encampment, right? Nobody wants to appreciate that they're necessary and might be life-saving at this point. And so really there's been resistance to any sort of state funding for it for that reason.
Have you found placement for these folks in next year when this funding runs out?
No, I mean, I don't think that they're going anywhere next year. It's just that the agreement to stay, it usually is renewed for, you know, so recently was renewed to 2025. And I don't know, I guess they could not renew it. You know, I think one big piece has been building significant public support for it so that I think the consequences of not renewing it or finding an alternative location would be quite high.
Thank you.
And I'll just speak very briefly. When our Health Canada funding was coming to an end, we did have a lot of discussion with the three main partners that were providing services on site at this particular location. And unfortunately, all three experienced changes in their strategic goal. And quite honestly, in alignment with their funding accountabilities, which were more about numbers of people served as opposed to the comprehensiveness of the services. Not only were we not able to sustain the intervention we introduced, but the baseline model, which had been in place since 2005 with the visiting providers, ended. And those services were withdrawn as well. And I have professional knowledge because I'm in the care landscape that there have been a lot of unintended results with that, with those changes. And so I think we have good proof of concept, and this is part of our work together is to try and look at the gaps between the homeless serving sector and the aged care sector, and where these individuals that we're seeking to serve and work with, where they're situated right now, because they're in really in quite a large gap in between. But I think we have great ideas of integrated social and medical models of care that we could hopefully see some positive things in the future. So that's our goal with these knowledge exchanges and priority identifications and more collaboration across the country. So on that note, I'm super mindful of our time. Thank you so much for coming today. This was our first endeavor in this regard, and really appreciate everyone online and everybody who came for lunch, and hope you have a great rest of your day.
That was an excellent presentation.
Thank you.
please feel free to take an extra lunch. It's like, more people sign up than they will come.
Yeah,
Would have been really smart.
either of mine came with 2 sandwiches, so I still have one in there.
Okay, done a lot of-
See you tomorrow.
Thank you so much, Denise.
Yeah.
Thank you both.
I got.
Okay.
Thank you.